Okay, so today we'll be talking about pediatric headache. This is a very common complaint you'll see in both the outpatient setting as well as the ED. And today we'll run through a couple things. One being the pathophysiology of how a headache starts and some of the molecules implicated in its progression. And then we'll move on to sort of classifying headache, how you can really build a framework for working up headache, differing between primary and secondary headache. And then we'll move into treatment of acute and chronic headache. They differ somewhat slightly, and there's some interesting data points that I'll kind of point out as far as literature for which there's actually kind of limited data on the management of pediatric headache, and it's kind of based all around sort of the management of adult headache. So we'll just jump in now. Okay, so starting with headache, it's actually the most common pediatric neurology complaint in children as well as adolescents. And it's actually, there's a 58.4% lifetime prevalence for adolescents, children to complain of a headache. There's actually a predominance for girls having more headaches than boys. And this is usually due to post-puberty. Essentially, there are menstrual-related headaches, and this is kind of why we see a predominance for girls. And then there's a very strong correlation with family history. So it's important you ask your families, your patients, if they have a family history of migraines or headaches. So moving into the pathophysiology of what actually causes a headache, like I said, there's sort of a genetic predisposition with family history, so it's important you ask that, but there's also environmental triggers, so things like the environment, whether it be the weather, food, certain triggers in the air. Those can be causes of environmental causes of headaches, so we kind of get this combination of nurture versus nature here when headaches are implicated. There's actually a predisposition for the hypothalamus to be kind of hypersensitive, and this causes depolarization along the occipital lobes of the brain, so depolarization of ion channels, and then this actually this depolarization spreads in a wave-like fashion sort of across the cerebral cortex until we get flux of inflammatory pathways, inflammatory molecules that I'll kind of go into now. And essentially what we get is the activation of trigeminal nerve afferent, so cranial nerve 5, as well as the release of peptides like CGRP, which are now implicated in some drugs that we target to treat headaches, and especially in adults. But this makes and causes inflammation in the brain, the activation of both the trigeminal nerve as well as the release of cyclic GRP. Now moving on to how we classify headaches, this can be easy to sort of develop a framework for how you work up headache, essentially. So let's see, we have primary headache, so things that we think of tension headaches, and then we also think of migraine headaches, and I'll kind of go into the difference between those two in a sec. And then classically, there's the third one, cluster headache. These are much more rare in children, so typically we get like a red unilateral swollen eye with some ocular symptoms, but very rare in children at least. And then when it comes to classifying secondary headache, there are important sort of red flags that you want to be asking for during your history portion so that you can sort of parse out, is this a secondary headache, is this a primary headache, and sort of go from there. Some of these red flags include systemic symptoms, so things like fevers, night sweats, chills, kind of constitutional symptoms you want to ask about. Focal neurologic deficits, so in your neurological exam, seeing if there's any deficits in that. And then leading into occipital headache, so headaches that involve the posterior portions of the brain. This can be implicated in cerebellar or posterior fossa-like pathologies. And then a couple other ones here, papilledema. So this is an ocular finding. You'll see kind of swelling of the optic disc implicating an increased intracranial pressure abnormality. So another red flag you want to ask about. Postural headaches, so things that are worse when you lie back. These can implicate, things that are related to also increased intracranial pressure. Altered mental status or loss of consciousness. This is obviously very potentially serious, so you want to ask about that. And then you also want to ask about any pattern change. So typically sometimes kids will have kind of their regular tension headache, but you want to ask about, hey, is this headache any different than the ones you've had in the past? And this can be implicated in potentially subarachnoid hemorrhage if it's like the worst headache of their life. That's one thing you also want to ask about, pattern changes. And then moving into some causes of secondary headache, we have idiopathic intracranial hypertension or pseudotumor cerebri, classically in a younger aged female, obese, treated with, I believe, diuretics as well as serial lumbar punctures to sort of relieve the intracranial pressure that's happening. You also see papilledema on exam. Other things like low vitamin D, that's one thing you also want to check. I learned on my pediatric neurology rotation that checking vitamin D is pretty much essential in treating headache. And you can also supplement, as needed if low. Things like anemia, obstructive sleep apnea are common causes of headache. And then potentially getting into the more serious ones, things like Chiari malformations, AVMs or arterial venous malformations in the brain. And something very simple you might want to ask about is a viral URI. Kids, they get sick very, very often, and a viral URI can be a cause of a secondary headache that you want to ask about. Tension headaches are described as sort of a bilateral squeezing sensation along the bilateral frontal parts of the head. Again, like I said, they're bilateral typically. They're not associated with any nausea or vomiting like migraines are, so they don't really cause sort of a debilitating nature per se, and there's no worsening with physical activity. Those are two key differences that are seen in migraine as compared to tension headache, kind of the nausea, vomiting, as well as the worsening with physical activity. And then moving on to migraine, there's a key mnemonic that is very simple to learn as far as knowing the key clinical signs of a migraine, and that's POUND. So P is for pulsatile. So instead of a squeezing pain, it's more of a pulsatile pain. O is for it lasts 1 day, but can go up to 72 hours in duration. U is for unilateral, but typically in kids also, it can be sometimes hard to differentiate, is a headache really unilateral or bilateral? So it's likely said in kids that these migraine headaches are bilateral just on the history. The N is for nausea, vomiting, and then the D is for debilitating. So these are worse with physical activity. You can get other symptoms associated with them, like with an aura. So we can have a plus or minus aura. These include symptoms like ocular symptoms, so loss of vision, flashing lights, even auditory symptoms, tactile simulations, even olfactory symptoms. These can be potentially signs of a migraine that are impending and give a clue to the person experiencing the migraine that they are likely to have one. There are other associated conditions with migraine, and these include things like cyclic vomiting syndrome, as well as abdominal migraine. So these are sort of abdominal complaints that come about and are associated with migraine itself. Cyclic vomiting is very sort of like clockwork, essentially. So these kids have profuse vomiting at a certain time of the day, certain time of the week, and they're very predictable in a way as far as classifying cyclic vomiting syndrome. There are really specific criteria to meet cyclic vomiting syndrome, so it's not necessarily a diagnosis you want to make right off the bat. It's more of a diagnosis of exclusion. And then actually one PIM question that I got on my pediatric neurology rotation was, what are two conditions that put the person at risk for developing migraines? And that is motion sickness or vertigo, essentially, as well as colic. So having an inconsolable infant child in which they're crying, and there's nothing you can do to soothe them. This is called colic. We call them colicky babies. So these are two conditions that put someone at risk for developing migraine in the future. Oh, I forgot something. I'm sorry. But if there's any of these red flag type symptoms, you're definitely going to get an MRI. This can be helpful in ruling out any potential structural causes of the headache. This is actually, better than CT. Typically, if we see them in the outpatient setting, an MRI is warranted if we see any red flags that I listed here. If there's no red flags, imaging is not necessarily warranted here, but sometimes people typically get it. It's not necessarily warranted. Again, like I said, MRI would be your imaging modality of choice if you see a red flag during your history portion. So we'll start with the acute management of headache. So the goal of this is to really stop the headache in its tracks so that someone is able to rest accordingly. And many of these treatments are for kind of migraine headache. There's more data for migraine headache than tension headache. So most of these treatments will be for the management of migraine instead of tension headache. Our first lines are, typical pain relievers like ibuprofen, Tylenol, or acetaminophen, as well as naproxen. And there's actually a key thing you want to know about the difference between ibuprofen and naproxen is that they have slightly different dosing schedules, essentially. And the reason for this is that naproxen has a longer half-life, so we can give it less frequently than ibuprofen. So ibuprofen we're giving more often compared to, say, naproxen. So second line, we have triptan drugs. These are actually serotonin receptor agonists, so at the 1B and 1D receptors. And these are common agents we can use if first-line therapy fails. And there are 4 agents that are approved in kids. 4 of them are called almatriptan, rizatriptan, zolmitriptan, and the classic one, sumatriptan. So all these are approved for ages 12 to 17 by the FDA. However, rizatriptan is unique in that we have an indication for ages 6 to 17. That's kind of one thing, a key clinical pearl that you may want to know is that rizatriptan is the one that's allowed for ages 6 to 17. There's actually a combination with naproxen for sumatriptan, like a formulation, if you will. And this was actually shown to be a pretty superior treatment in randomized clinical trials. So a good option to use if you want to double dose someone with an NSAID plus a triptan. As far as dosing goes for these, we typically like to give only 1 dose in 24 hours, but we can give up to 2 doses within 24-hour period. If we have nausea, vomiting associated with the headache, things like perchlorperazine, which is a dopamine antagonist that acts on the chemo trigger zone in the brain to stop nausea or vomiting. So it's a D2 antagonist. And then a classic ED migraine cocktail will consist of, like I said, perchlorperazine, also IV fluids, I believe IV Benadryl, as well as something called IV ketorolac, which is another NSAID that was shown to have about 55% effectiveness in clinical trials for reducing acute headache. Perchlorperazine, on the other hand, was actually 85% effective, so more superior comparing it to ketorolac. But when used in conjunction, I think they're the most effective. And this is sort of where the idea for the ED cocktail came into play. If we're giving these 2 agents in conjunction, we'll have a pretty good chance of abating the migraine for the child. And then finally, if there's a last resort option that we have in our back pocket, that's actually dihydroergotamine, which is a powerful vasoconstrictor ergot alkaloid agent that has very specific guidelines as far as like the treatment protocol. I won't get into that now, but that's sort of our last resort for treatment of acute migraine. And then sort of on a similar note, actually, for the triptans, there are some contraindications that you definitely want to know as far as, do we give these, can we not give these? So these are contraindicated in kids with ischemic vascular disease because of their vasoconstrictive properties. So ischemic vascular disease, as well as arrhythmia. I'm not sure what the reason for the arrhythmia contraindication is, but those are 2 contraindications for triptan therapy. So here's a summary of the acute treatment of migraine, and then we'll move on to chronic here. So as far as for the treatment of chronic migraine, one thing that we in pediatrics really like are lifestyle modifications. We want to be doing our part so that children can remain headache-free by doing the least amount of work as possible, or the least amount of invasive procedures as possible. Things like medications can have side effects, so we like to recommend lifestyle modifications at the outset of managing chronic headache. Okay, and there's a good mnemonic that I like to use for lifestyle modifications, sort of in general, for kiddos. So one is sleep. We want kids, at least adolescents, to get at least 8 hours of sleep. If they're less than 11, 10 years of age, more than that, so about 9, 10 hours of sleep. So A is for adequate hydration, and the rule that I like to use and talk to parents and children about is that they're drinking half their body weight in ounces. So if they weigh 100 pounds, they want to be drinking at least 50 ounces of water per day. R is for regular exercise, so averaging at least 150 minutes of exercise per week. That averages around 30 minutes a day or so. This is something that can really be a great lifestyle modification for the prevention of migraines. And then finally, T is trigger avoidance. So kind of keeping tabs as to what sorts of things may be triggering their migraines, and then also what sorts of things we can do to prevent migraines from happening. So some kids like a dark room, taking a nap, allowing children to go to the nurse's office at school for about 15 or so minutes when the migraine kind of peaks at its highest. Those can be things that are helpful as far as modifications so that a child can really be at their best, whenever they're at school or doing anything else. Next is actually cognitive behavioral therapy. This is something that I found very surprising, actually. So getting kids to develop coping strategies with a psychologist, psychiatrist who does CBT is actually shown to be super, super effective. The odds ratio in a meta-analysis of about 14 studies actually was about 9.18. And I think the range was about from like 5 to 14. So odds ratio really, really strong here as far as reducing headache severity and reducing headache days by about 50%. So that's sort of the marker that they use to measure how effective CBT was. But again, this odds ratio is super, super great. So another thing that you can use in your toolbox and recommend CBT for kids suffering from headaches. Okay, and then finally, to round off our treatment of chronic headache, we'll be going over pharmacologic management of headaches. And this is sort of indicated, especially when headaches are debilitating and they're frequent and they're just kind of having an impact on the daily functioning of a child. And these, in my experience on my pediatric neurology rotation, if they're happening more than 2 times per week, this is typically when we'd start a daily preventative medication. So some ones that have been studied in kids, the one that actually has kind of the most data is actually topiramate, which is actually a treatment for epilepsy. It's a sodium channel blocker. It increases GABA activity. So there's a lot of mechanism that's still kind of sort of unknown about topiramate. But some of the evidence suggests that topiramate can decrease headache severity and headache days for children. Things to know as far as adverse drug reactions you want to be counseling your patients about include a cognitive slowing. It can actually be teratogenic and cause, I believe, weight loss as well. Next up is ciprofloxacin, which is a first-generation antihistamine H1 blocker. Typically also used in the setting of decreased appetite in the GI clinic. In my experience, it was also used to increase children's appetite. But as far as adverse effects, it can make children pretty sleepy. So it's one of those H1 blockers that pass the blood-brain barrier, similar to Benadryl. You can get really bad kind of fatigue and sleepiness when you take ciprofloxacin. So we like to give it and dose it, especially at night. And then one other agent that was seen in my experience was amitriptyline, typically at a lower dose than used for, say, depression. So it's actually a tricyclic antidepressant. But in this case, it was used at a lower dose, a sub kind of depression dose to treat headaches. You want to be counseling patients about as far as adverse drug reactions, anti-HAM side effects, so antihistamine, anti-alpha, and anti-muscarinic. So when we think of antihistamine, right? So things like sleepiness, sort of similar to cyproheptadine. Anti-alpha, you want to be counseling about orthostatic or the potential, orthostatic hypotension. And then also antimuscarinic side effects, so things like kind of dry eyes, blurry vision, constipation, things like that. And also super, super important to counsel as far as amitriptyline goes. If you overdose on these, it's very, very difficult, treatment to see is cardiotoxicity. So we want to counsel patients in saying that, hey, you're taking the right dose. You're only taking one of these. You're only taking 2 of these, so that we prevent any potential cardiotoxicity. I think it actually widens the QRS complex on EKG. So potential cardiotoxicity you want to be counseling about as far as a dangerous side effect for amitriptyline. And then a couple other ones here. So the CGRP antagonists, so the GPANTs, are not actually approved in children under or people under 18. So we're still looking for an approval or an indication for these in children. So not able to use these at all in kids for management of headache. And then other preventative agents, things that have pretty low side effect profile that don't really show too much positive data in the literature, include vitamins. So things like vitamin B2 as well as CoQ10. Those are some things that we can give sort of low side effect profile as a potential preventative if these headaches are less than 1 to 2 times per week. And finally, one thing that I learned about that was super, super interesting is this thing called Nerivio. It's actually not a transcutaneous. It's a remote electrical neuromodulation device that acts sort of like an armband on the child's arm, and it provides sort of sub-painful electrical stimulation to abate migraines. It's used for the treatment of acute migraine as well as the prevention of migraines. So you see here, Nerivio, this is this kind of armband here that can be used for kids and teens. It's actually approved in as low as 8 years old, I believe, and it's sort of a daily preventative. It's pill-free, needle-free. This is one thing that I learned about that was pretty cool as far as kind of new developments in migraine treatment. It's, like I said, it's a wearable device that acts as both a preventive agent as well as an acute migraine treatment through non-painful and safe stimulation. Okay, that wraps up our video here on the management of migraine or headache in kids. So today we went over kind of acute treatment, chronic treatment, pathophys, some red flags, as well as the clinical features of tension headaches, migraines, and the sort. So appreciate you watching, and thanks so much.